Okay. It's not moving. The slides are not moving. Okay. So we know that if we go back to 20 years ago, almost half of the valvular diseases, even severe and symptomatic, were not treated because of high morbidity and mortality burden. And therefore, percutaneous treatment was developed for really inoperable patients. But with time, we gained experience and confidence, and now we have new guidelines in Europe that came now. And the question is, are we going too far with that, and what is the current landscape? So let's start with the aortic valves. If we go with the aortics, let's go. I'm going to give you headlines and then a few details. So we know that today we have very widespread use of TAVR. We are now focusing more on the lifespan rather than on the procedure. A few years ago, all we wanted was for the patient to get out of the operating room alive. Now what we want is to have the patient live 20 and 30 years after his procedure and be healthy. We have more awareness of the importance of cardiac damage, and we are discussing whether we should expand to moderate AS and to asymptomatic patients. So we know now that today most of TAVIs are going skin to skin around an hour or even less, mainly femoral with local anesthesia and sedation. So we've come a long way from what we had a few years ago. And the question regarding whether we should go earlier for patients with moderate AS has been discussed this year. And we had this TAVR unload study that actually failed to prove a superiority of early treatment of moderate stenosis, but it actually showed that it does improve the quality of life of the patients. The other question was early TAVI, that was presented earlier this year with Généreux, New England Journal again, and this time it showed that there was an advantage of early treatment of aortic stenosis. So what actually was happening is a lot of conversion to aortic replacement when the patients were left untreated, and this is kind of non-surprising. So if we look at what's happening today in the ESC guidelines, the guidelines in Europe were revised, and today the cutoff is fixed at 70 years. So any patient beyond 70 years is actually going, if he has a tricuspid valve, is going to be a candidate for TAVI. Of course, there will be a case-by-case discussion according to other comorbidities of the patients and anatomy, but basically we can consider that any patients more than 70 years is a candidate for TAVI, less than 70 is surgical patient, and between the two, so patients with bicuspid, patients who are around 70 but with other risk factors are going to be discussed. So it's a level 1, it's a good indication. We've also seen that today we are including a lot of other criteria to send the patient for intervention, and those include high gradient aortic stenosis, elevated BNP, progression, LVEF that is decreasing, and we don't know why, except that we consider that it's aortic stenosis, and if on exercise test we have a fall in blood pressure. Valve-in-valve is becoming widely spreadly used. So today, of course, we are going to treat patients with valvular dysfunction that is not a thrombosis, and it's a 2AB if we can treat those patients with TAVR, with valve-in-valve procedures, if they are at intermediate or high surgical risk. Just to say, it's also what is recommended for mitral and tricuspid. So a lot of place is given to valve-in-valve procedure, whether they are aortic, mitral, or tricuspid, as long as the patient are at intermediate or high surgical risk. Aortic regurgitation, we started seeing some dedicated valves being commercialized, but the recommendation is still a 2B recommendation. First, we should consider surgery and switch to TAVI if we consider that the patient is not eligible. So it's still a small recommendation for aortic regurgitation at this point. In mitral regurgitation, one important thing that happened is that today we are really distinguishing atrial from ventricular secondary mitral regurgitation. This is a new concept. For ventricular secondary mitral regurgitation, today edge-to-edge procedures should be considered even before surgery and regardless of the risk of surgery. And we also understand today that doing a procedure for ventricular secondary mitral regurgitation is only one step in the patient's treatment. So we should continue with medical treatment afterwards. So this concept of atrial SMR that we've seen, this is a slide from the guidelines, so now it made it to the guidelines, is really distinguishing those patients with ventricular dysfunction and leading to secondary MR. And this is typically our cardiomyopathy patients, our ischemic patients, and atrial SMR. Atrial SMR, we have a normal ejection fraction, more than 50%, no real LV dilation, but actually we have annular dilation on the mitral, enlarged left atrium, and this is typically atrial fibrillation patient and HFpEF. So in the guidelines, there's a real distinction today between the two scenarios. If we look at the primary first, so the primary, it's a 2A recommendation for edge-to-edge today, if the patient is suitable. And the discussion, the cutoff should be made according to the surgical risk. So high surgical risk and feasible for edge-to-edge, then it's going to be a TEER procedure. If we look at secondary here, there's a lot of distinction between atrial and ventricular. In atrium, it's still a recommendation 2A for valvular mitral valve surgery and a 2B for edge-to-edge. So we should prefer a surgery if we can. For ventricular, it's different. For ventricular, they say edge-to-edge is class 1. So first consider edge-to-edge regardless of surgical risk. And if we see that the patient is not a good candidate, he doesn't have the good criteria, he's not anatomically feasible, then in this case, we should consider surgery, but we can also, in case of advanced heart failure, discuss LVAD or transplant or whatever. So here's a typical case of DCM. I'm going to go quickly. This is a dilated cardiomyopathy patient, and we see this is a typical case. We are moving, just to show you that today we are completely moving away from the Everest criteria, the very severe, simple case of A2P2. Here we see that actually the posterior leaflet is so restricted. This should not be a patient for edge-to-edge a few years ago, but today we are moving more and more to the doable patient, and sometimes to the hard or impossible. And if you look at this patient, we decided to still go for the intervention, and it is feasible because we have new generations now and several sizes of clips, and therefore here we did the procedure despite the small posterior leaflet, and we have a good result. So improvement, the changes in guidelines, but also improvement in technologies leading to good results and to challenging cases being performed. One last word on the tricuspid regurgitation. So now we know that we have a proven benefit in reducing the tricuspid regurgitation. The benefit is obvious on the quality of life and on heart failure hospitalization at 2 years. We don't have real proven data on mortality, but we know that it's important to select the patient. Here again, we know that atrial TR is 25%, ventricular 60%, so basically we are mainly treating secondary TR patients. We have several techniques. Oh, the video is not working. So this is an example of percutaneous replacement. This is the evoke valve that can be advanced through the femoral vein and then all the way to the valve. It looks easy and simple, so we have to grasp the leaflets and then open the valve above the valve. It looks quick. It is quick actually, but we have to have good imaging if we want to perform the procedure, and the results are pretty reassuring with almost no residual TR left. Edge-to-edge is also an option, and if we look at what the guidelines are not taking sides. They are saying transcatheter therapy, that could be edge-to-edge repair or replacement, because we know that today annuloplasty is not an option. So transcatheter therapy could be an option in patients with severe TR if we consider that they are symptomatic and not candidate for surgery. So in conclusion, this is a very active domain if we are talking about percutaneous treatment of valvular disease. We have some great results, and one thing is for sure that it's very important to refer early and select the appropriate patients for the procedure. Thank you for your attention.